Very good evening to all. So I'll be talking on anti-VEGF agents, new agents in the armamentarium. So anti-VEGFs, you know, are the mainstay of treatment for neovascular AMD, diabetic macular edema, and retinal vein occlusion. Most of the anti-VEGFs require intensive treatment to dry the macula and to achieve optimal treatment outcomes. However, patients often experience a high medical and financial burden due to the injection cost as well as multiple comorbidities, and that this can lead to high rates of non-compliance, under treatment, and in turn lower visual gains in the long run. So this is one study which has shown the diabetic macular edema treatment in India. We know although 5 to 7 injections are needed in year 1 for best results, the DME treatment in India is often found to be suboptimal. Only about a third of the treated DME patients completed 1 year follow-up, and more than only around 80% received 3 or less intravitreal injections during 1 year period. So although around 5 to 7 injections are required in the year 1, mean injections per eye in this study was found only to be 2.1, so which is grossly under treatment. So the anti-VEGFs, you know, the commonly used, which has been used for the last 2 decades are ranibizumab, bevacizumab, and then aflibercept came. And what are the newer agents? So the newer agents, innovations in the field, offer better treatment efficacy as well as longer interval between treatments. So we'll be looking at 2 agents mainly, the brolucizumab. So it was FDA approved in July 2019 for neovascular AMD, and in 2022, June 2022 for diabetic macular edema. So what are the advantages of brolucizumab is it has more VEGF binding ability per volume, and also it delivers more molecules than aflibercept in the same volume, almost 12 times more than aflibercept. So these are the 2 landmark trials, Hawk and Area trials, where they have compared brolucizumab with aflibercept. So we will be seeing briefly the outcomes of the study. You could see here the brolucizumab was non-inferior to aflibercept for the mean change in VCAB at week 48, which was the primary endpoint, and this was maintained till week 96 in both the studies. And also proportion of patients who gained more than 15 letters from baseline or who had a BCVA of more than 84 letters at week 48 or more in the brolucizumab group. Coming to the anatomical outcomes, what was interesting, this brolucizumab new molecule helps in gaining superior reduction in central subfoveal thickness, and this was maintained till 96 weeks in both the studies. And also the subretinal or the interretinal fluid reduction, if you can see here, it was more in the brolucizumab group compared to the aflibercept groups. Also the sub-RPE fluid, which is most of the anti-VEGFs don't address the sub-RPE fluid. Brolucizumab is one agent which helps to reduce the sub-RPE fluid also, even in the real world examples we have seen. And almost another advantage is the 6 milligram dose of brolucizumab helps to maintain every 12-week dosing, and after the initial loading phase. So this is another advantage. We can phase out the injections after the initial loading phase every 3 to 4 months. So these are the other studies for brolucizumab in DME, Kestrel, and the KITE studies. Again, you could see similar results similar to the neovascular AMD. Brolucizumab was non-inferior to aflibercept. So these are the visual outcomes which are similar to aflibercept, and also the proportion of patients who gain more than 15 letters were better in the brolucizumab group. So these are some patients which we had treated. You can see the RPE fluid, sub-RPE fluid, after 2 injections it has almost resolved along with the subretinal fluid. Again, in a CNBM, after 1 or 2 injections, we could see the intraretinal fluid and subretinal fluid has completely disappeared. So one issue with brolucizumab is the ocular safety profile. So these patients with systemic ocular vasculitis or uveitis, these patients can develop vasculitis or vascular occlusion. So this we should be careful in these patients. So next agent is Vabysmo or faricimab. It is the only agent which is acts via 2 distinct pathways. It is known as a bispecific monoclonal antibody. It also blocks angiopoietin 2 in addition to vascular endothelial growth factor 1. So these are the trials for faricimab. Again, we could see here 4 monthly dosing was maintained in almost 50% of the patients in all these studies, which we have shown for both diabetic macular edema and neovascular AMD. So this is another advantage of this newer drug. So this is again a real world evidence of patients initially non-responsive to aflibercept. They have responded well to faricimab, and the vision was maintained at the end of 2 years. So another newer modality of injection is the pre-filled syringe, which has come. The Eccentrix has come with a pre-filled syringe, and even the ranibizumab biosimilar Rezumab is coming up with a pre-fill syringe. So what is the advantage of the pre-fill syringes? It reduces the injection time and loading related risk of endophthalmitis, and sometimes some air bubbles can go inside the vitreous cavity. So that is reduced. So again we have the biosimilars, you know. So there's the biosimilars which are currently available in the market. These are also many of them in the last 3-4 years they have been launched, and even Eflivase biosimilars are now available in the market. Even the biosimilars show good results, especially in diabetic macular edema. Even in CNBM, if the patients are not able to afford the brolucizumab or Eflivase, we have gone ahead with the biosimilars. They have shown good response. So to summarize, the newer agents offer long drug durability. Injection intervals can be phased out to every 3 to 4 months. And the brolucizumab, we should be careful in patients with active uveitis. So young patients, again with CNBM, we should look for any evidence of uveitis and try to avoid brolucizumab. And the sub-RPE fluid that currently is being addressed by brolucizumab very well. Thank you.
Thank you for nice presentation. I think anti-VEGF is like such a huge area, and all of us and everybody, in fact, we are blessed in retina, and that something like that came in and made so much of difference to the patient and to us. I think what you said already, the problem with the newer ones, especially when we go back to the ones which are available, and you already talked about diabetic and the under treatment, the real world experience. You see, what we have seen, and we were not able to do that earlier. Diabetic patients are different. Some of these diabetic macular edema patients, once we undertreat them, you are treating them forever. So once patient, we had biosimilar, even like Irasumab, or when Eylea became under a scheme, in some of these patients, at least we have followed the protocol, given 5 injections of Eylea all the way, and subsequently you find that they need very little injection, maybe once in 3 or 4 months, and some of them, they were free of injections. So I think that you should keep in mind. What is happening with VEGFs at this time? We are not able to give loading dose, we fear that vasculitis. So we are treating forever. So what is happening is that we let it come back and then we give another injection. So there is no end point. That is where there's a lot of things are happening the way we are treating in this country, because it is a very good drug, very effective, dries out everything, but then because of that fear, we are only using PRN. So that doesn't get really in the long run a benefit. So whatever trials have been done, even if you use 6 injections in diabetic macular edema of something like Razumab or any of these biosimilars, you will find similar results. And that is where you reduce the number of injections, and ultimately by 3rd year, you may have just 1 or 2, 3 injections. You will get rid of that, but not otherwise. That is what I'm saying. Yeah, well, that will be subsequently, but the question is, how do you treat them optimally, give them the best, as well as in the subsequent year, you're going to reduce their burden, and much less injection and visits will be there.
So according to the concept and what you're saying, so just one thing. So supposing a patient is there who has 20/60 vision with DME, we give 2 injections as per the loading dose protocol, and by the third visit, his fluid is dried up, his vision is 20/20. Now, Dr. Neil Breston and DRC say you should give 6 injections, as you are saying. So should we stop there, or should we still give further injections if the DME is dried up?
Actually, that's where the problem is. DME sometimes dries up with first injection, and we stop, and we want then that to come back, and that becomes PRN right from beginning. So that is where our problem is. So we have to somehow believe these trials, and that's how they have said that how you reduce, especially in DME. It is a different ball game altogether. So that's what I was mentioning. That is where we are. Because once it is dry and we want it to come back, it becomes PRN. So then it doesn't work. Yeah.
Even I think that gap or the void is still there. Even I think aflibercept is coming up with a higher dose.
Yeah.
They are coming up with 4 times the normal dose, and that also may be available very soon. So ultimate aim is, as you said, to reduce the number of injections over a period of time, and the cost. So I don't know.
Yes.
The end point we still don't know.
Yeah, I think in diabetic you can achieve end point. In AMD it is different ball game.
Yes.
Perhaps very difficult to achieve, very few. There you may have to consult patient differently. They might require sometime lifetime injections. There, the natural disease also catch up. So that is different. So we are dealing with all different kind of things. Thank you very much.